this is the first HIMSS where we've not had any formal public sector leaders coming in to tell us which direction to take. So it's an opportunity for the industry to take a bit of a breather to learn what we can do together in anticipation of the change in administration. So what I'm going to try to do is walk through what I believe are the big opportunities. And obviously we'll have a little bit of a dialogue, so we're going to have a little bit of a flat connection. But the headline is, we have a specific opportunity that I announced yesterday called the Neighborhood Watch. And I'm going to explain what that is and how people can be a part of it. By the way, you're going to have to be a part of it too. So we've had a decade of success in interoperability. Upen was one of the first to do bulk fire. In fact, he remains one of the few approved vendors by CMS for the, right, DPC, you're still, okay. So let me take a step back. We have agreed as a country on 3 fundamental things. Thing 1, an open data model will be the foundation of data sharing. Thing 2, we've established a set of rights, which I'll describe. And thing 3, we've got a very clear path for improvement through industry collaboration. So open data model, rights, and collaboration. So what's the open data model? Well, the open data model in FHIR is that every vendor who has a proprietary system has the obligation, or can do it voluntarily, map their data into the FHIR format. What that means is third-party developers who interact with that information are not bound by any licensing rights or IP constraints. So it allows for true market innovation on what you can do with the information now that it's in an open format. The rights are an exciting list. Right number 1 are the consumer rights. That's what, Eric, I've been asking of you when you bring patients in with families. They can actually, if they can identity proof themselves, they can more easily pull their records from all the different locations into one format. And the Trump administration is building on that to include price transparency rights. They have the right to a good faith estimate. And then they were talking about the opportunity to strengthen our quality roadmaps. The second one is the right that I think is the least understood. And it's why I've announced this Neighborhood Watch initiative. Clinicians have rights. Clinicians that are buying these certified EHRs, including your own, they have the right to access their own EHR records and download an app of their choice to help them make use of them. So that's the Smart on FHIR protocol, which is part of the Cures Act requirements. Secondly, every doctor has the right for their health systems to give them an update if a patient shows up in the emergency room. Now, Eric, you're going to be my test. How many doctors have been able to go to the local hospital and say, I want my records? The reality is there isn't a form for that. So you're in the HIE, you're lucky. Florida has an HIE, so you can do it through the network. But absent that, actually in Puerto Rico, you're doing it, theoretically. Whatever the case may be, the vendor ADT network is a gift, but the right is inherently to the physician. So if there's no HIE network, they still have the right. And it's up to the hospital to meet them in a readily producible format. And now with the TEFCA treatment networks kind of going live, doctors have the right to assemble medical records, at least for treatment purposes. Now, this is the most controversial part of the rights. And this is a bit complicated. For companies like Arcadia, we live at the payer-provider interface. Every certified EHR has the technical ability to filter data to share with a partner by contract. So if you wanted to share with Humana, you should be able to partition your records to share with Humana, and vice versa. They will do the same for you. These rules are now bipartisan and locked in. So if we have an open data model, we have rules. We ended with Mickey's final blog post on his very last day in office, which you should look up, Passing the Baton, where he said very specifically, interoperability between payers and providers is critical to driving efficiency in the healthcare system. And this is the next chapter of value-based care, decoupling the data sharing from the value-based contract. It should just be care. So if I'm a doctor, I have the right to pull the records. This initiative that Mickey announced was sort of like a handoff to the rest of us to see if we can make a difference. And so Mickey announced an initiative that he referred to as the 10 by 10, or technically it's 10 1x1s, where one payer and one provider are willing to share data with each other in the FHIR format. And if the technical approach works, we can scale it nationwide. I'm grateful to Blue Cross Mass, Elevance, Emory, Epic, Humana, Meditech, Providence, and Tufts. By the way, Arcadia works with most of those folks who are willing to do this in at least one test market. And the message I conveyed yesterday was that we need more. We need more early adopters to facilitate payer-provider sharing so we can put to the test whether these rules work in the open data model. So that was the headline of the message yesterday. A little bit more background. The idea was, if the government's not here to give us a speech about where they want to go, what would we anticipate they do? So I said, let's go back to first principles. Let's anticipate the demand signal. So back in 2009, before I was in the government, I was on the transition team. Myself, Todd Park, Farzad Mostashari, and a couple colleagues, we wrote an open letter to David Blumenthal, and we basically said, please, HIT policy should not be about the technology itself. It's about the use of that technology to improve chronic care management, as an example. And I highlighted that sentence because what was the executive order to introduce the Make America Healthy Again? It was as if President Obama had written it. By the way, it's one of those, it's a Trump executive order, but if you read the words, it's a mom and apple pie. It's like, help the kids, prevent and slow down disease progression. And the most exciting thing about it is it's built on the principles of transparency and open source data. This is the Trump executive order saying the exact words in the Obama framework. So that's very positive. They then added a price transparency order where they added the notion that a consumer should have the right to request the prices. And so this is a great demand signal for what we should be building towards. And to kind of get to the chase, my view is the gaps that remain technically are going to be gaps that will be addressed through new collaborations built on FHIR. And I highlighted this because obviously with the Trump administration coming in, there's going to be an open question. How much longer are we going to maintain two technical standards in healthcare? At the moment, we have the EDI standards, the X12 standards, and these are designed for administrative transactions, billing, referrals, prior authorization. But when the CMS team put out a rule for prior authorization, they decided to send two different rules, an EDI version and a FHIR version. And we know how that movie ended. The CMS team said we're going to put enforcement discretion so nobody has to do the EDI version, and we're going to double down on FHIR. So that just was the beginning of a step to say, wait a minute, if that's the case, every gap that remains should therefore be closed in a FHIR format. So the three gaps are a TEFCA for operations gap, the ability to have coverage and benefits, and this idea of a consumer navigation feature. So I'm just going to say a word about each. On TEFCA for ops, the core question is, if I am trying to share data with Humana or with a clinical registry or with whomever trusted partner is, either I give them access to the, as I jokingly call to it, the all-you-can-eat buffet FHIR server, where they can query, and I trust that they're only going to query for people that match, or I might put a filter to say, hey, I've already pre-filtered patients that are in this program. So an ACO working with Eric's guide model could say, hey, here are the dementia patients that are in our population today. Eric, here's how I can coordinate with you with your virtual clinic so we can coordinate that care and actually get the family better results and ideally lower costs for the system. So that local physician network could filter for just that population of dementia patients, and then you can query it to ensure you've got a feedback, and then you could do it in return. Say, hey, here's the subset that came from your clinic, and then they want the same access. So how do we technically do that? To me, that's the work of the 10 by 10 or the 10 1x1s, and to me that's going to be a facilitated FHIR program. So UPenn is live with the CMS FHIR server called DPC, data at the point of care. This allows a doctor to say, hey, I've got 100 patients, give me their records. CMS takes that request from UPenn, says, yep, we agree, 93 of them do have a treatment relationship with you. You've seen in the last 18 months. Here's the key that's only good for the 93 patients. And so UPenn is hitting that server right now, and it updates weekly, DPCs weekly. In ACO Reach, it updates daily. The second gap is in coverage. I announced that the VA interoperability pledge is live. So Sanford and Marshfield shared data. About 3% of Marshfield Clinic's population are active veterans that they had no idea because there was no mechanism for them to know, are you a veteran? And Sanford was asking the question, but had no validation of it. So they were at, they got up to 4% of their population. And here's the thing. When Sanford did this, 50% of the veterans had a presumptive eligible condition in the Sanford EHR that would have qualified them for more benefits from the VA. So that veteran would not have otherwise known if they didn't think to apply for more benefits. But now by having a health condition, the doctor was able to say, by the way, that condition's paid for by the VA. You shouldn't worry about copays and other things. So that today doesn't show up in the eligibility verification 270, 271. That's going to come through the FHIR resource. And so our Karen Alliance IG for Blue Button does have a mechanism for exposing coverage data. At the moment, it doesn't communicate veteran status, Humana member, eligible for Meals on Wheels, but we should do that. And so that's the second body of work. And then last, but certainly not least, on the consumer navigation part, right now, I call this a race to the top. If I do the identity proofing through Clear or ID.me, Face ID, the TEFCA networks, the EHRs have agreed that they will respond with information. So I can have my mom aggregate her health records from the dozen or so doctors she's seen, and I can put them in an application that we as a family trust to help us navigate her care. So at the moment, those rules exist, and we're going to do this in the state of Washington. I'm glad you're here. Come here, get here, public sector guy, get over here. He's running the prior auth program for the entire state of Washington. And you need to, this is going to be you, Chris, so you're going to have to do it this way. And the point is, this feature, we announced yesterday, we need to have a race to the top. So we want to know, can we get rid of that condition called hyperportalitis? Or my mom has 10 different portals from her primary care specialists in the field. And so this way, if she has Face IDs with her passport, that can be her digital health passport, and then she can interact, check-ins, pre-fill out the forms, all the rest. So these are the main issues that I covered in our remarks yesterday. And I end with this sort of, I had a couple examples of this. This is what that physician rights looks like. This is a Smart on Fire app from Apple that's natively integrated into Cerner, Oracle. A patient can say, I've got data on my phone, I'm going to give it to you, doctor. The doctor downloads this app at no cost. They click this button that says Apple Health Records. It shows up in context in window. There's no integration fee. There's no physician license fee. And there's no patient fee to turn on the feature. This is a $0 interoperability use case. This is the Clear experience on the Be Well patient app, which allows you to verify and aggregate your records. And then in our ACO Reach work at Arcadia, we've been doing research. Consumers are opting in to value-based care networks, 13%. Eric's going to be at 100% in the guide model because we're going to say, I want to be cared for by you. So this role of consumerism and the ability to aggregate data, that's coming. So finally, this is what I'm asking people to do. What I want to do more than anything else is launch the Neighborhood Watch. Okay, so this is where I need your help. Today's ONC is required by statute to do real-world surveillance of all the FHIR endpoints in the field. So that if you're a doctor, Eric, and you purchased an EHR, did you get sold a lemon? Does the FHIR server actually work? You have no idea. You don't even know how to turn it on. Where is the light switch? How do I use it? So do you know how to use the darn thing? Can you give Chris application access to your FHIR server so he could run a Washington State Medicaid program? Under what terms and conditions would you restrict access? It's kind of a trick question because you're not required to impose terms and conditions. But if you wanted to, because there's a specific project where you want to establish a DUA, you can do that. Third, Can we design our own filters with a group ID token so I could limit the data sharing to a mutually agreed population? That is ostensibly a feature in the rules, but it's not 100% clear anyone knows how to actually turn on those features. And then obviously questions like, should I do a one-time access or an always on forever, something in the middle, 3 months, 6 months, 9 months. These are decisions. If we can't answer these questions in the real world, then we're not getting the full bang for the dollar of what our investments are in the electronic health record system. So Brendan Keeler has offered to help. We're going to go deep on that this afternoon, I think at 4 o'clock. But Brendan's going to join me and a bunch of others to say, hey, we're going to start testing the fire servers. And we're going to celebrate Health Samurai's aid box as one of the best. And we're going to just demonstrate that these things are going to work in the real world. So that's what I shared yesterday. And we got a few minutes. We want to have a bit of a dialogue. We got luminaries today. By the way, we got a QHIN and Health Gorilla. We got the policymaker and prior auth. We got the first DPC API. We got a guide model participant. So there's some heat in this room. Questions, comments, reactions. Are you ready for Neighborhood Watch? Would you be upset if we started hitting the fire servers in the real world? Go for it. He's got a few health plans that are live on the interop rules, so we could go. Flexpa's done this, by the way. They did Neighborhood Watch for the payer rules. Now we got to do it for the providers. Correct. At the moment, data monetization is complicated, but it doesn't really fall under your authority. If anything's happening, it's between you and the BAA vendors that say, hey, I'll offer you a product if you give me the rights to monetize. So this is about, maybe you might develop your own program where you can find a way to bring value in. I don't think people are going to sell data. I think they're going to want to use the data to create a better program, like a world's best dementia program. And maybe pharma might want to work with you on clinical trials because you've got clear evidence, a nice longitudinal record. So there's a lot that this could mean in terms of organizations. All right. We're happy to mingle. Thanks, everybody.